Hello, my name is Erin Meyers. I am the Medical Director of Apheresis and Associate Medical Director of Transfusion Services at Nationwide Children's Hospital in Columbus, Ohio. Welcome to this Pearl of Laboratory Medicine on transfusion support in hematopoietic stem cell transplant, or HSCT. The objectives of my talk are a brief overview of the different types of HSCT, followed by a review of the sources of HSCT available and transfusion thresholds for patients receiving the different types of HSCT. Finally, I will discuss ABO-incompatible HSCT with a focus on the complications of and transfusion support for each possible ABO-incompatible combination. Hematopoietic stem cells came to light after the dropping of the atomic bombs in 1945. People who survived the initial explosions later died of bone marrow failure from radiation. A series of sentinel experiments by Till and McCullough in the 1960s then showed that transfer of bone marrow cells from donor mice into lethally irradiated recipient mice resulted in the formation of colonies of myeloid, erythroid, and megakaryocytic cells in the recipient's spleen approximately 7 to 14 days later. Stem cells have two very unique properties: the ability to self-renew and the ability to regenerate. The field of stem cell biology has only grown, and HSCTs are able to be transplanted now to recipients to help a variety of diseases. It can be used to eliminate a bone marrow infiltrative process like leukemia, or to correct a congenital immunodeficiency or hemoglobin disorder. Also, it can allow patients with cancer to receive higher doses of chemotherapy that the bone marrow can tolerate with subsequent rescue with a bone marrow transplant. The length of transfusion support and type of transfusion support is dependent on the patient's underlying condition, types of previous treatment, dose of stem cell transplant, and conditioning regimen. Patients can receive stem cells from themselves, which is called an autologous transplant, or from another person, which is called an allogeneic transplant. Allogeneic HSCT has a potential graft versus tumor effect and thus results in low rates of relapse. But this is a trade-off because it also has a high risk of graft versus host disease. Autologous stem cell transplants do not have a risk for graft versus host disease, but also has no graft versus tumor. And there is a risk of the stem cell product possibly being contaminated with tumor cells. Disease type, patient factors, and the presence of a related donor influence the type of HSCT used. There are three major sources of HSCT used clinically today: bone marrow-derived, peripheral blood-derived, collected by an apheresis machine, and umbilical cord blood-derived. The bone marrow transplant physician will help select the most appropriate source based on the patient's clinical status and HLA type. Traditionally, the source of hematopoietic stem cells in an autologous and allogeneic transplantations was bone marrow. This remains one of the most commonly used sources for pediatric allogeneic transplants. It is derived by multiple aspirations of the posterior iliac crest of the hip. Bone marrow-derived HSCT have a low number of T cells, thus less of a risk of GVHD, and they engraft at a moderate pace. The use of peripheral blood as a source of these cells has replaced bone marrow for most autologous transplantations and a significant proportion of allogeneic transplantations, especially in adults. Donors are stimulated with a hematopoietic growth factor such as G-CSF, and the stem cells are collected on an apheresis machine from peripheral whole blood. Peripheral blood HSCT have a large number of T cells and thus the highest risk of GVHD of any of the stem cell sources, but they are also the fastest to engraft. Umbilical cord blood is collected at birth directly from the umbilical cord, then banked. It has the lowest rate of engraftment of all the stem cell sources and is gaining in use in both pediatric and adult stem cell transplants. The conditioning regimen prior to an allogeneic HSCT is important as it provides the necessary innate immunosuppression so that the graft is not rejected, as well as helps to irradiate the disease process. Traditionally, myeloablative regimens have been used, but due to high levels of chemotherapy and/or total body irradiation required, it is fraught with toxicity, and they are often not well tolerated for older patients. These regimens have good innate tumor control, but can have delayed engraftment and require longer transfusion support. Non-myeloablative regimens or reduced intensity regimens are also used to try to induce a state of mixed chimerism between the donor and recipient to help induce graft versus tumor effect. These regimens minimize toxicity to the patient and can be used for older individuals. Patients who have received an HSCT will require extensive red cell and platelet transfusion support until their stem cell transplant and grafts. These patients generally do not require plasma and/or cryoprecipitate transfusions, as the HSCT process typically does not affect the liver where coagulation factors are made. Red cell engraftment can be hard to evaluate, but is generally defined as the presence of at least 1% reticulocytes in the peripheral blood and the absence of RBC transfusions for 30 days. Platelet engraftment is defined as a platelet count of at least 20,000 per microliter for 3 consecutive days without any platelet transfusions. Neutrophil engraftment is the presence of an absolute neutrophil count of greater than 500 for 3 consecutive days. For the majority of patients in the peri-transplant and post-transplant phase, a hemoglobin level below 7 grams per deciliter would warrant a red cell transfusion. There is evidence that patients immediately after surgery or after cardiopulmonary bypass or with a pre-existing cardiovascular disease should be transfused below levels of 8 grams per deciliter. There are no set hemoglobin transfusion levels for a patient who is actively bleeding. The hemoglobin should not be the sole determinant for transfusion. The patient's entire clinical picture must be taken into consideration. Autologous HSCT maintain adequate erythropoietin levels throughout the post-transplant course and require less intensive RBC support as compared to allogeneic. Factors affecting the duration of RBC support include the dose of erythroid progenitors in the stem cell graft, if the graft is ABO incompatible, the type of myelosuppressive drug used, and the presence of graft versus host disease. Platelet transfusion thresholds vary depending on clinical situations. Generally, in a stable, non-febrile patient, a platelet count of 5,000 to 10,000 per microliter is a reasonable platelet transfusion threshold. A patient on heparin should be maintained at a level greater than 20,000, and a patient with significant bleeding should be maintained at a level of 50,000. There are several factors that affect the duration of platelet support after HSCT. Patients who received a graft from an unrelated donor generally require a longer course, as does the presence of acute graft versus host disease, veno-occlusive disease, or CMV infection. Other factors affecting platelet transfusion support are the number of stem cells infused, the use of bone marrow as a stem cell source, and the use of methotrexate for graft versus host disease prophylaxis. Neutropenia causes significant morbidity and mortality in HSCT patients. Granulocytes may be used in specific instances to assist these patients. They may be indicated for patients with an absolute neutrophil count less than 500 per microliter with either a bacterial infection unresponsive to antimicrobial therapy or an invasive fungal and/or yeast infection. The minimum dose of granulocytes of 1 times 10 to the 10th per infusion is necessary to determine any clinical benefit. The clinical utility of granulocyte transfusions in neutropenic patients has been unclear. Therefore, the RING study, RING, or randomized controlled trial of G-CSF-stimulated granulocytes in granulocytopenic patients attempted to examine the efficacy of high-dose granulocyte transfusion therapy. The study was carried out in 14 sites as part of the NHLBI Transfusion Medicine/Hemostasis Clinical Trials Network. Subjects eligible for this study were those with neutropenia, defined as an ANC less than 500, and with proven, probable, or presumed bacterial or fungal infection. Subjects were randomized to receive either standard antimicrobial therapy or standard antimicrobial therapy plus daily granulocyte transfusions from normal donors stimulated with G-CSF at a dose of 450 micrograms and dexamethasone at a dose of 8 milligrams. The primary endpoint was a composite one. It included survival plus a microbial response, both evaluated 42 days after randomization. The study showed no benefit of granulocyte transfusion therapy in these patients, but the power of the study was greatly reduced due to low patient accrual. Although the HLA system plays a critical role in identification of compatible related and unrelated donors for HSCT, the red cell antigens, including ABO, are not part of the HLA system. Unlike selection of donors in solid organ transplantation, ABO compatibility is not considered critical in selection of potential HSCT donors because stem cells do not express ABO antigens. The relationship between ABO types of the donor and recipient can fall into one of four categories: compatible, major incompatibility, minor incompatibility, and bidirectional incompatibility. Since HLA and ABO antigens are encoded on different chromosomes, some degree of ABO incompatibility occurs in 20 to 50% of allogeneic HSCTs. There is no conclusive evidence that ABO incompatibility significantly impacts overall survival, the incidence of acute or chronic graft versus host disease, or relapse rate after allogeneic HSCT. A compatible transplant is one in which the donor and the recipient have the same ABO type. A major incompatibility occurs when the recipient has ABO antibodies, or isohemagglutinins, against red cell antigens present on donor red blood cells. For example, when the donor is group A and the recipient is group O. Minor incompatibilities are defined as the presence of donor ABO antibodies, or isohemagglutinins, against antigens present on the recipient's red blood cells. For example, the donor is group O and the recipient is group A. Finally, a bidirectional incompatibility is the existence of both major and minor incompatibilities. For example, when a group B donor donates stem cells to a group A recipient. It should be noted that these terms are more frequently used in the context of the ABO system, but they are and should be used to describe the presence of other red cell antibodies, such as anti-Cal or anti-D, in the plasma of the donor and or the recipient. Generally, however, ABO incompatibilities are the primary concern in clinical practice. This table lists all the potential ABO combinations that could exist between a stem cell donor and recipient. Overall, ABO incompatibilities are present in approximately 20 to 15% of donor-recipient pairs. They can cause both delayed and late complications, and transfusion support is a major cornerstone of treatment. There are several immediate and delayed complications to each type of ABO incompatible HSCT combination. The main complications of major ABO incompatible HSCT are RBC hemolysis at the time of graft infusion, delayed donor red blood cell engraftment, and pure red cell aplasia. Red cell depletion of the major incompatible HSC graft should be considered to prevent acute hemolysis at time of graft infusion. Red blood cells comprise approximately 25 to 35% of marrow product volume, which is over 1,000 milliliters typically for adult recipients. And thus, incompatible red blood cells during bone marrow infusion pose a significant risk for acute hemolysis. Another strategy for major incompatible HSCT is to reduce the recipient's isohemagglutinin titers transiently around the time of infusion by plasma exchange via apheresis, though there is no consensus with regard to best practice of this strategy. In minor ABO-compatible HSCT, the passive transfer of donor isohemagglutinins in the HSC graft may result in acute hemolysis during stem cell infusion. However, a delayed form of hemolysis can also occur due to the persistence of donor lymphocytes generating antibodies and is called passenger lymphocyte syndrome. Strategies to mitigate the infusion of a large volume of incompatible isohemagglutinins include plasma reduction of the stem cell graft. Bidirectional ABO incompatibility contains both major and minor ABO incompatibility. The clinical manifestations of bidirectional ABO incompatibility include the potential for immediate and delayed hemolysis similar to that caused by major and minor incompatibility. Clinical approaches to lessen the complications of bidirectional incompatibility include a combination of practices for both major and minor incompatibility. Please bear in mind that the HSC product manipulation strategies do incur the risk of HSC loss and delay in HSC infusion, and do not protect against delayed red blood cell engraftment, pure red cell aplasia, or passenger lymphocyte syndrome. Transfusion support is required after transplantation before red blood cell engraftment, which may take up to 6 weeks or longer. Transfusion support is especially critical in ABO-incompatible HSCTs and is outlined here. The principle behind appropriate selection of components is to provide, during the transplant phase and until recipient antibodies are no longer detectable, components that are compatible with the ABO groups of both the donor and recipient in order to minimize potential hemolysis. There are no set national standards for transfusion support during ABO-incompatible HSCTs. Each institution must define its own policies to maximize safety specific to the patient populations and transplant protocols. This table is organized into the following 3 clinical phases. Number 1, pre-transplant phase, which is from diagnosis until prior to initiation of the conditioning regimen. Phase 2, the transplant phase, from a conditioning or preparative regimen until recipient isohemagglutinins are no longer detectable and recipient red blood cells are no longer circulating. And finally, phase 3, the post-engraftment phase, defined as after the front and back type of the recipient have converted to the donor's ABO group. Patients who have received a major ABO-incompatible HSCT should receive red cell transfusions of the recipient type and platelets and plasma of the donor type during the transplant phase until the recipient has converted to the donor's ABO type. This is the exact reverse for recipients receiving a minor ABO-incompatible transplant. Red blood cell transfusions until the recipient converts to the donor type should be donor type, while platelets and plasma should be the recipient's ABO group. Bidirectional incompatibility patients need to have Group O red blood cells and Group AB plasma and platelet products until they convert to the donor ABO type. Management of platelet transfusions in ABO mismatched HSCT patients can be challenging since Group AB and Group B platelets are hard to find. The ABO blood group system is not a barrier to successful allogeneic HSCT transplantation. However, the institution performing ABO-incompatible HSCTs must have a clear understanding of the potential adverse events and have systematic policies in place for transparent communication between the transplant program, HBC processing lab, and the blood bank to help mitigate such events throughout the donor selection and transplant process. The transfusion service is a critical partner in providing compatible blood products throughout the entire course and helping to assist the transplant team should adverse complications arise. Thank you all very much for participating in the AACC Clinical Chemistry Pearls of Laboratory Medicine. This pearl was Transfusion Support in Hematopoietic Stem Cell Transplant. My name is Erin Meyers. I'm the Medical Director of Apheresis and Associate Medical Director of Transfusion Services at Nationwide Children's Hospital. Thank you so much for your time today.